So as we talked about earlier, disc degeneration is very, very complicated, and there's all kinds of different pathomechanisms involved in why the disc fails. But ultimately, the end result is the final common pathway with loss of proteoglycans, water, disc height, et cetera, as we've talked about. So when we're talking about novel biologic strategies for disc degeneration, I'm in the thought process that philosophically, from a paradigm standpoint, it's best to intervene prior to end-stage degeneration. Because once the disc has catastrophically failed, like a big ruptured disc, or the disc is collapsed down to nothing, it's probably too overwhelming for the biological system to beat out the mechanical loading that's occurring in that disc to be able to adequately regenerate a disc to a normal level. So with that in mind, we want to consider altering this balance, this paradigm that we talked about, the simple model of synthesis and catabolism of matrix biology. And I think we have some windows of opportunity to consider treating the disc in that mode so that we can make a difference. So basically promote synthesis and decrease catabolism, which occurs in terms of the disc matrix biology and homeostasis. So how do we do that? Before we want to describe this, and then we want to try to get into translational mode in treating patients, but you can't obviously experiment in humans, so we have to have good animal models of disc degeneration. And I would say from the outset that there's no perfect animal models of disc degeneration, because most animals are quadrupeds already, and we humans happen to be bipedal, so there's never a perfect model, and there's always shortcomings to each model. But there are certain advantages of certain models with certain basic science questions that you can answer. So we can go back to the mice and rabbit. Doing any more larger animals are extremely expensive, as those of you who are involved in research will know. But mice and rabbits are still expensive, but they're better in terms of cost containment. So we've been talking about annular fissuring, annular tears, whatever you want to call it. If you want to mimic this, we have studied this, and if you puncture the disc with a 16 to 21 gauge needle, and this is what was referred to earlier, our group and Howard On's group in Chicago simultaneously actually involved in developing this model, and get an annular tear more or less. And you can debate whether this is a true model, because people believe that most human tears occur inside out, not outside in. But that's a matter of debate. But if you use a large, relative bigger needle, and I must say the size does matter in terms of diameter and the gauge of the needle, but suffice it to say, if you puncture the disc and injure the annulus enough, you will get a progressive disc degeneration. We took these rabbits, this is about 12 years ago, and took them down to MRI scanners in the middle of the night and did these MRIs longitudinally at 3, 6, 12, and 24 weeks. And you can see that the disc goes through progressive degeneration compared to the control disc, which we did not stab. And then if you do quantitative MRI indices, you can see there's a precipitous drop in the MRI signal within the nucleus pulposus in the stab disc versus the controls. And correlating the MRI findings with X-ray findings, you can see that there's a progressive disc osteophyte formation that occurs until the disc degenerates pretty significantly, mimicking the human condition. And histologically, you get a significant loss of cell number, and then slowly over a course of time, over a 6-month period, you get fibrosis of the disc, large osteophyte formation. And again, this seemed to be very commensurate with what happens in the human condition as the disc progressively degenerates and becomes very arthritic. And we studied this model actually very extensively from a molecular standpoint. And if you take the disc and start identifying the various genes that are being turned on or off, as you might expect, as I stated earlier, in disc degeneration, you lose aggrecan. And then when you start at different time points, start studying the different genes for aggrecan and type 2 collagen, you can see there's a precipitous loss of aggrecan and type 2 collagen genes that are being expressed. So that's commensurate with what's happening in the MRI findings. Interestingly, type 1 collagen, which is a sign of progressive fibrosis, increases as you might expect. Now, what about the anabolic genes in this disc? The anabolic genes that we studied at the time were BMP7, BMP2, IGF. These are common growth factors that are known chondrogenic agents. And if you study that in different time points in terms of gene expression, you find that there's a precipitous loss in the early goings. There's some attempt at the disc to try to repair itself, but it just ultimately doesn't really cut out, and something else happens as the disc fibrosis. If you look at the other component to the bad cytokines, for instance, tissue inhibitor of matrix proteinases, it just inhibits the enzyme that degrade matrix, or TIMP, as you might want to call it. Again, there's a precipitous loss after the puncture, and it never recovers. So think about this model. In our animal model, we've identified certain genes that get turned off and never come back on. So if you're thinking about some type of a genetic or therapeutic biological treatment, once you understand what's happening from a molecular standpoint, you might have good strategies to consider turning this around. So with that animal model, we are now in hand to test various therapies. And gene therapy was something that was introduced to me by Chris Evans in Pittsburgh back when I was a resident, actually, back in the late 80s. And Chris Evans was one of the first to introduce gene therapy for musculoskeletal diseases. But initially, it was conceptualized as treatment for diseases caused by single gene defects. And so what you're essentially doing is introducing a gene that the patient or the animal is deficient in, and then introducing that genome into the deficient host in the hopes of curing these diseases. There's been some moderate success. Are doing it in muscular dystrophy and animal models, and SIDS patients, there's been some moderate success, although there's been some safety issues as well, as we'll get into. But you're essentially adding this gene into the host in the hopes of curing diseases or altering natural history of diseases. And there's various different ways to introduce these genes, and as you all know, the viruses are the best in getting into the cell, because that's how they evolved over billions of years to make us sick. They know how to invade that disc, throw their genes into the host, and take residence in it. So viral constructs are probably the best in terms of delivering various DNA into a host. But there are some non-viral ones. A lot of people have investigated, but the basic fundamental premise is that viruses do a much better job. Now, there are some safety issues here, as you might expect. But again, this is the concept. A virus is great in getting into a cell and then incorporating whatever its genome into the host. And that's the concept that the gene therapists have used. So essentially what you're doing is gutting the virus of any pathologic genes, inserting the good genes that you want in there, and then putting it into the cell. And early on, about 10, 12 years ago, I got this notion that, hey, maybe we can do that to the disc. So if you take disc cells that are natively in the intervertebral disc, and then you throw some viruses inside of it, will the disc cells take up, and will they produce the proteins that you want it to produce? The theory behind gene therapy is that what you're doing is creating a biofactory of cells that are producing the growth factors of interest, so you get a steady concentration being produced. Unlike if you just decide to throw or inject proteins into the disc itself, like growth factors, BMP, so forth, that we know the half-life of those growth factors is about 20 to 30 minutes in vivo. So you won't get this continued concentration. You'll just get a blip, and then you hope it has a therapeutic effect. But we know in a chronic degenerative disc condition, that's probably impractical. And people have tried it, obviously. This is one of our early data that demonstrated some promise with one-time injection with an adenovirus with a LAG-C protein that we injected into the disc. These cells took up the virus, and after literally 6 months, we still had pretty strong transgene expression. So that gave us some impetus to move forward with this. And started thinking about how we're going to consider various treatment options. So again, main goal was to restore proteoglycan homeostatic balance in the hopes of altering the imbalance that occurs with degeneration. So you can either promote synthesis or inhibit the catabolic processes that that is associated with this degeneration. And there's various different cytokines that one can use, BMP, 2, 7, all these growth factors that are chondrogenic in nature make cells produce more matrix. And then there are also anti-catabolic genes that you could throw in here that could make a difference in terms of this homeostasis. If we go back to that animal model that I already described, you can see that as the disc progressively loses this matrix, that there are certain genetic molecular events that occurred that I already showed you. So if we're going to strategically introduce a gene, we felt that as the disc is degenerating, at week 3, based on our gene PCR work, we felt that if we could introduce a BMP gene early on when the disc itself precipitously loses that gene, we might be able to potentially either regenerate the disc or delay it. So that was our premise. So as you can see, our main goal here is not to treat the disc at this stage, because I don't know how successful we would be, and I don't think we would be. But if we can intervene early, maybe we can alter the natural history. So we did some early studies years ago with stabbing the disc, and then 3 weeks later introducing the adenovirus. Back then, that was the very popular virus because it was most widely studied and was very effective in transfecting cells. And you can see that when you injure the disc and then inject just saline as control, you get progressive disc degeneration, as we have seen. But if you inject adeno-BMP2, boy, you get continued maintenance of that disc. And so after we got some early results, I was doing backflips. I thought, boy, we've solved disc degeneration. Piece of cake, no problem. Just, you know, as in the OR, when you high-five yourself, bad things start happening, right? So this is exactly what happened. So that things were going well, and we were very intrigued, but around this time is also when the critical patient in Philadelphia, Jesse Gelsinger, was injected with too much adenovirus by the quote-unquote conflicted investigator, and the patient unfortunately died of an immunologic reaction from the adenovirus. So that gave me a little scare, of course, and we're using the same adenoviruses. And I said, well, before we start going public with any of this, we want to do the safety trials in our rabbits. So what we did was study it, and we wanted to see what the immune reactions were with the adenovirus, and we were worried about uncontrollable gene expression of BMP. So what if, rather than injecting the disc, someone accidentally injected the epidural space by mistake? That could happen, potentially, or it leaks out. What would happen? Or what would happen if someone accidentally injected too much virus, overdosed the animals? Well, it turns out that when you do that, you get into trouble. As I was investigating this, I realized how potent BMP can be. And it exists in picogram quantities in the body, but when you're delivering milligram doses into the body, some things could potentially happen. And so when we started injecting these rabbits in the epidural space, bizarre things started happening. Now, we injected some TGF-beta also, and that causes paralysis in some of our rabbits because the meninges took up the virus, and the dura, and it got so thick it paralyzed the rabbits. And then in some of our rabbits with BMP, some of these rabbits started developing severe paresthesias. And then when animals get paresthesias, the numbness in their paws, they think it's not their body, so they chew their paws off. So, and then we had some other interesting systemic reaction to BMP. But we didn't know at the time whether this was BMP or whether this is the immunologic reaction or the synergy between the immunologic reaction and the BMP. Because we were able to identify that in these rabbits, there was high levels of BMP circulating in their blood. So the biofactory was churning out a lot of BMP. So these rabbits that developed paresthesia, they had all these spinal cord changes with foamy macrophages coming in. So there was something going on. We didn't know if this was an immune reaction or just direct results of BMP. So this is all published. We published this about 7-8 years ago, actually. And the repeat issues of BMP safety is coming all around again. And you see all this chondrogenic metaplasia that occurs out in the meninges. It's fascinating what happens when you overproduce a certain cytokine that Mother Nature gave you for a certain specific reason. That quashed our high-fiving, and we just said, oh boy, we got to take a step back. There may be a little bit more safety issues here. Although the adenoviruses were very good and delivered in the appropriate manner into the disc, it worked beautifully. But there's no way any of the governing bodies would let us use this now that we had our own data showing the potential safety issues. But what about other viruses? There's much safer viruses now that are being developed, adeno-associated viruses. There's no known human pathologic conditions associated with it. It's a more difficult virus because it doesn't give you the transfection rate as well as adenovirus. You get a lot more blue cells than the AAV virus, but nevertheless, it's probably enough. And we did another whole series of animals with AAV virus with BMP. And when you do that, again, you see it wasn't as great as adenoviruses, but we were still able to maintain the matrix and alter the natural history. We also used the TIMP gene. Again, in our model, TIMP gene was significantly suppressed at the 3-week mark, so we introduced TIMP gene, and again, we were able to maintain some of the matrix. Now, it wasn't, again, not as great as the adenovirus. When you look at our quantitative MRI values, the therapeutic genes of BMP and TIMP altered the natural history. This is the degeneration that occurs with just a stab. So we were able to bump up the curve. We were never able to get it back to normal, but we were able to alter the natural history. So we still believe gene therapy has a huge potential. It's just we have to figure it out a little bit better and study it better. When you do histology, when you do the stab, you see loss of the disc cells in the nucleus. And then when you add BMP, you can maintain the cell matrix, and the cells maintain themselves much better. And it's very similar to TIMP. So now we haven't done an animal model where we introduce both BMP and TIMP. We're working on that, trying to introduce both genes at the same time to really alter the matrix homeostasis. And my chief resident, Steve Leckie, presented this, and he did a lot of the work on this particular study, and we won a little award at the North American Spine Society this past year. And when we do the same toxic experiments with AAV virus, you don't get any of the problems, actually. So it would seem that the adenoviruses and the BMP, for whatever reason, was having a synergistic effect. We still don't know the full matter, but when we do the toxic studies injecting AAV virus in higher concentration of the virus in the epidural space, we don't see any significant downside to it. But it doesn't mean it's not absolutely, there's no potential dangers in it. To add a level of safety, we're moving forward with inducible systems, which means that, all right, you can infect the cell with the virus, it'll just sit there, and the gene won't get turned on until we give that animal a certain drug, and then that inducible agent sifts into the gene, and once it binds, it turns on the gene. So you can theoretically inject the disc with the virus, and it incorporates, but nothing gets turned on. And then this Rio gene, which we've been working with a company, you take this ligand drug, and it gets into the disc. As soon as it gets into the disc, it turns the gene on. So you can control it. And if you take the ligand away, the gene production stops. So that adds a layer of safety to the gene therapy potentially. And we've shown this in our rabbit model when we inject the AAV, the Rio gene switch with the GFP on/off, and then when we add the ligand, it turns the gene on. And then when we take it away, the protein, the transgene transcription stops. So from my perspective, gene therapy I still think has some potential. It's controlled, targeted, sustained gene expression within the disc, and we've shown that we can do it. Potentially more effective, less expensive than other ways of treating it, but safety issues still a concern. I think there's still a lot to be researched, but there should be some cautious optimism. And gene therapy can also be utilized in conjunction with cell-based therapy. I don't have time to go over all the stem cell work that us and other people have done, but gene therapy in its own right, I think, has potential. We just have to control it. So I think all of these issues going forward, there's many labs working on all aspects of this, mechanobiologists, gene therapy, cell-based therapy, and we're going to have to put it all together at some point. But again, I would temper my enthusiasm about regenerating the disc once it's gone through late stages. My goal is to just alter the natural history, and we've shown some animal evidence that we've been able to achieve that. And all of our lab people I want to thank. Thank you.
I'm just going to go on and expand a bit on what Jim has so eloquently started off, biological repair of the disc. So I think we would all agree that the disc is a very oblique structure in the sense that we really don't understand all about it. We don't understand its biology fully, and we don't understand fully why it undergoes this degeneration and why certain individuals develop chronic pain. And so it's really not surprising with that background that we've developed a number of treatments, all of which seem to have some degree of limitation. If we really don't understand the mechanisms, it's not really that surprising. And even current attempts to improve on some of these therapies have really caused us sometimes more problems. So with that kind of background, it's really not surprising that people started to ask the question, well, you know, the real issue here is that we don't understand what's going on. We don't have the right treatment yet. Perhaps the reason people aren't responding is that we really haven't identified the right treatment. And maybe we need a whole entirely different approach to individuals who have chronic back pain. And so the whole field of biological disc repair started to bloom and blossom. And it's over the past 10 years, there's really been a plethora of investigators who have started to look at different aspects of biological disc repair, and a whole variety of different approaches have been developed. Obviously, disc degeneration can have a variety of presentations. It can be early disease where we've just lost a little bit of the matrix. It progresses on to more severe disease, and it's clearly not one treatment is going to be appropriate for all of these different manifestations. So if we start off with the first category, the individual who presents with very early disease in which there are cells present, but there's been a loss of extracellular matrix and some evidence of symptomatology. Well, what can we do? So from a biological point of view, the cells are there. What we need to do is stimulate those cells to replace the matrix molecules that have been lost. And there have been a number of approaches developed. Growth factors, as you've heard, gene therapy. These are all different ways that we can stimulate these cells to make the right matrix. And this is just one slide that Koichi Masuda shared with me, in which he was able to show that if you create an animal model of degenerative disc disease with a needle puncture, 4 weeks later, when they have the degenerative changes, if you inject GDF5 or OP1 into that disc, you can restore disc height. And it was just one injection. And that was clearly very intriguing, and there's lots of biological explanations for that. We know that the half-life is short, but these growth factors can bind to the matrix molecules, and they may actually hang around for a lot longer than what one might expect. But it really does give hope to the approach of perhaps using this idea of injections into the disc to stimulate the cells. And whether it's a growth factor or a TIMP inhibitor or a gene therapy is yet to be determined. Now, if we go on to the next stage of disc degeneration, that later stage when we've lost our matrix, now we're starting to lose cells. So the idea of stimulating cells by injecting a growth factor, for example, will probably not work. And it's that group of individuals who might benefit more from an injection of cells into the disc. So if we can inject cells into the right spot, the cells can produce the matrix and regenerate the disc. And interestingly, there have been two groups who've actually looked at doing that. And they've been focusing in on repair of the nucleus pulposus, because that perhaps is maybe the earliest tissue that we might want to repair. And so there was one group in Germany, the Meisel group, in which they isolated disc cells from herniated disc tissue, expanded their cell number in culture, and then injected it back into the intervertebral disc. And they have done this in over 100 patients, and they reported back on follow-up on just over 20 of these patients. And what they were able to show is that with a 2-year follow-up, that these individuals had decreased pain and increased hydration. But you will note that the paper was published in 2007, and we've had no further follow-up on this group of individuals. The second study is a much more recent study, and this is a pilot study. This is a group from Spain. Instead of taking the individual's disc cells, they took autologous mesenchymal stromal cells. So they didn't have to actually damage the disc tissue in any way. They just took a bone marrow aspirate, purified out the mesenchymal stromal cells, and injected it back into the disc. And interestingly, at 1 year, in their 10 patients, they were able to show that those patients had decreased pain and increased hydration. So this is really a proof of principle study that suggests that injections of mesenchymal stromal cells might be an appropriate approach for individuals with that early stage disease in which there's been a cell loss. And there's a lot of experimental data to demonstrate that the environment into which mesenchymal stromal cells are injected can influence what they do. So that may be the mechanism of action. Alternatively, these mesenchymal stromal cells may actually be secreting growth factors or a variety of other factors that could be stimulating matrix production by the cells and therefore feeding back onto these mesenchymal stromal cells. So there's still a lot of work to be done, but it's a very promising pilot study, and they're continuing their clinical trial. But we've been sitting here and we've heard a lot of discussion, and we had a very eloquent presentation by Michael talking about discography and intradiscal injections. And clearly there's a lot of evidence now in vitro models, in animal models, and most recently in the CARTILAGE study, in which they were able to demonstrate in their cohort study that patients who had discography had advanced or accelerated progression of lumbar disc degeneration. So clearly, this approach of injecting growth factors or cells into the disc has to raise some concern. And one way to get around that would be to develop different ways of delivering these agents or cells that doesn't require needle puncture. And that's a very active area of investigation, delivery of drugs without puncture of the tissue. Another approach would be to actually deliver the cells in a way that would retain the cells within the tissue. And clearly, that's an approach that one might use for more advanced disease, where you've got more tissue destruction. And I've already showed you a little bit of the work that we've been doing in terms of delivering annulus cells to a defect. And there are a number of people who are also working in this area. And this idea of delivering cells in a scaffold allows you to hold the cells in place. So you, as Jim mentioned, if you inject something, it has the potential to go in a variety of different locations. And it also allows you to create a tissue structure that is more closely mimicking the native tissue. And individuals are using a variety of number of different scaffolds, and the journals are full of it, of all this literature. We don't know the answer yet. There probably is a scaffold out there that is really going to allow you to accomplish what you want for a particular type of tissue. I'm obviously biased by our studies in the polycarbonate urethanes, but it's a very promising approach. Again, there's been no clinical trials utilizing this approach. And the other problem with implanting scaffolds is the question of fixation. How are we going to fix that implant in? So we all know that disc disease can present with very severe degeneration, more of an end-stage process. And as Jim has mentioned, Obviously, injecting cells or cells in a scaffold for one type of tissue is clearly not going to work. We've got damage in the nucleus, we've got damage in the annulus, we've also got damage in the cartilage endplate, and we now have information suggesting that that damage is what causes pain. And so if you tried to fix one tissue, you'd still have problems with the other tissues. And we also know that if we're creating an animal model and we just damage one tissue, we ultimately destroy the other tissue. So in a situation where you've got multi-tissue damage, it would make sense that one would have to replace the entire disc. So no longer could we expect the tissue to regenerate itself. We actually have to provide the disc with the tissue. And we have to provide all pieces of the tissue, as for some of the reasons I've mentioned, but also there is evidence that suggests that it's very important for viability and maintenance of this tissue. And we've done a study in which we have grown nucleus pulposus cells, as you can see here, in the presence of cartilage. So we know that the intervertebral disc has a nucleus layer and has a cartilage layer. And there's potential reasons for why that cartilage layer is there, but we were intrigued by the question as to whether it could actually have a physiological effect on the nucleus cells. And what we found is that when we grew the nucleus pulposus cells in the presence of this cartilage, we generated much better and thicker tissue than we did in the absence of this tissue, in the absence of the cartilage. So clearly, the cartilage was having an anabolic effect on the nucleus pulposus cells. And this is just to show you that this difference in tissue thickness is not because there were more cells there, because the cellular content was the same whether you grew the cells in the presence or absence of cartilage. So it was truly an anabolic effect. And when we went on to further characterize why this happened, it turns out that the cartilage was secreting a factor that inhibited TNF-alpha production by the nucleus cells. And so we've heard about NF-kappa B, which is activated by TNF-alpha, and we know that these tissues produce TNF-alpha, which is a catabolic stimulating agent. And it may be that with the loss of the cartilage layer, that the production of catabolic cytokines goes up, and that's why we have progressive disease. So we really need to replace all three components of the tissue. And I would argue that you actually have to replace the bone component as well because of the recent results from the Battier group. We hypothesized that at the end-stage disease, really what you need to do is replace the disc with a bioengineered disc. Now, when you stop laughing, I will point out that there is evidence that complete disc replacement is a viable consideration. There's animal data, and somewhat recently, there has been a study published by Luke and his colleagues from Hong Kong, in which they implanted allograft disc tissue into the cervical discs of a number of patients. And their 5-year follow-up was very promising. And I understand that they're going to publish shortly the 10-year follow-up, which is equally positive. But we all know that allogeneic implants is really not a true viable option. And so bioengineering a disc is something that you could do using the individual's own cells and get around all the problems of allogeneic tissue. So the other support in favor of a disc replacement was recently published by Roger and Larry Bonassar and their group, in which they used a tissue-engineered disc and generated a tissue-engineered disc, which they implanted in rats. And this is their data, which I've borrowed from their paper. And they show the disc that they've taken out, the disc that they generated, which is collagen around an alginate core, which contains cells in it. And this is the tissue 6 months later when they harvested, and it maintained disc height. So very promising proof of principle that disc replacement will work. But of course, this is a rat, and the rat disc is very, very small. And so all of the other problems associated with it have not been addressed, which is the problems of diffusion and real weight bearing. But it's definitely very exciting proof of principle that the concept of replacing a damaged degenerate disc with a biological disc replacement is a possible option. So we've taken just a slightly different approach than their group, because we felt it was important to replace that layer of calcified endplate for a variety of reasons. We know that it's sclerotic and that will impair diffusion of nutrients and that it may be the source of pain. So the first thing that we did in this quest to make a biological disc was develop a bone substitute material that we think would be appropriate to support tissue formation and replace the bone that we would ultimately resect. So together with my colleague Bob Pillier, we worked on developing a bone substitute. He utilized calcium and phosphate, which is the natural molecules that make up bone, and developed a method to generate this bone substitute, and this is just its appearance as a cylinder. And you can appreciate in the scanning electron microscope that this substitute is porous, and that's important because the bone has to grow into it. And we were able to demonstrate that it was biodegradable and had strength similar to bone. And when we implanted this tissue into rabbit bone, and we've done it into rabbit and sheep and a number of other animals, you can see that the bone substitute, this white material, is in place, and the bone, which is black, grows through the pores. The other thing to note is that there's no reaction to it. So it's something that is well tolerated by the body, in part because it's made from calcium and phosphate. So we had a bone substitute that we thought was appropriate to use. So the next question we asked was, can we grow tissue on this bone substitute? And we started with the nucleus and cartilage endplate as our first goal, and we developed the methodology to generate this tissue. And this one image represents about 3 years worth of work. And what you can see is the tissue on the top surface of this bone substitute integrated with this material. And you can see the layer of the nucleus pulposus tissue and the layer of the cartilage. And these tissues are integrated with the underlying bone substitute. So we have this component of the disc ready to go. So the next question we asked, as you well know, is, are we going to be able to generate an annulus fibrosus? And although I've talked about the patch, we were really also interested in generating an annulus fibrosus that we could use in making this intervertebral disc. And so we've generated multi-layer annulus fibrosis, as you can see here. You can see the scaffold and the intervening annulus tissue. And again, this is a tissue that doesn't have all the properties of the annulus, but we're expecting that once it gets implanted, that these tissues will mature up. And we have evidence in our cartilage work that this is exactly what happens in vivo. It turns out that the body is very much the best bioreactor. So we took this tissue and we wrapped it around the nucleus pulposus construct that we had. And what we ended up with was a model of an intervertebral disc. And here you can see it from the lateral aspect. You can see the annulus is adherent to the bone substitute material. And when you look at it from the top down, what you can see is the nucleus tissue surrounded by the layers of the annulus fibrosus. So we have a model, we think, of a intervertebral disc and bone substitute, which we think is ready to try in vivo in an animal model. And this is just to show you this is the nucleus pulposus tissue, the layers of the annulus, and they're really integrating very nicely. So it's exciting times for us in particular, but for the patient, we're still obviously a distance away from having a disc replacement, and there are still a lot of issues that need to be addressed. And we've been talking about it in this morning, but there are other issues as well. For example, we've been using the cells of the animal. Can we use human cells to make these tissues? Well, we all know that the disc really doesn't have very many cells, and some of the cells that are there are actually senescent and may not be appropriate to use. And we also know from our own studies that young cells make good tissue, but older cells don't make such good tissue. So the age of the individual may play a big role in what kinds of tissues we can generate. So if we can't use the individual's own cells, we can use stem cells. But the whole question of what stem cells to use, should we be using embryonic stem cells, inducible progenitor cells, or these mesenchymal stromal cells? The answers are not in yet, but there are a lot of people working on it and addressing some of the issues related to these cell types. Then we have the additional problem of trying to place the implant, and that's something I think that most of you are aware of. Clearly, arthroplasty is not an easy procedure. Biological disc probably will have some of the same problems, but we will learn a lot from arthroplasty. We also need to be able to assess the implants. You know, what's success? How are we going to define success in these individuals? And that's really an issue, I think, that's generic to everything that we do, not just biological disc replacements. We also have to remember that we're putting this disc into an end-stage disease disc spot or location, and these individuals can have an inflammatory environment. There may be lots of cytokines floating around. They may have facet joint disease, which will add another layer of complexity. But again, these are all problems that can be addressed. And then finally, and I think we've talked quite a bit about this in the morning, what patients really would be suitable for this kind of approach? And these are all vexing questions, but they're actually broadly applicable not only to biological disc repair, but to all of the treatments that we offer our patients who suffer from chronic pain. So, biological repair of the disc, it is our future. It's an entirely new approach to how we handle these patients, and hopefully we will have better outcomes than we are currently having because we're truly being able to address the problems of the disc and what is causing the chronic pain in these individuals. But only time will tell. So I would like to just acknowledge all the people who have been involved in the study and all the funding support we've got. Thank you.
The question to the audience is, has lumbar disc replacement had a positive impact on spine care? Can I have a show of hands? Yes. Can I have a show of hands? No. Can I have a show of hands? I don't care. Can I have a show of hands? I don't know. Okay, it's a majority. Good. All right. Very good. So what about this then? If this is you, this is not some abstract patient. This is you. This is Heather. This is Randy. This is Scott. And you've just hit a wall. You've gone through, I'm going to make a plug here, UBC, or Rehab Institute of Seattle. You've gone through UW Rehab. You've done everything. And you just can't handle this anymore. Would you, number one, have a fusion? Can I have a show of hands? You just can't go anywhere. You'd have to quit work. Nobody has a fusion. Number two, disc replacement. 3, 4. Definitely no surgery. Retire. As a business model, the spinal column with its 23 discs, and that's a ±2 calculation, 53 joints is a real setup for failure over life, and we've seen unbelievable lectures today. The disc as a nidus of pain has held a fascination since the medieval ages. And again, what I'm going to talk about is the true sledgehammer approach towards literally knocking the pain out of that disc by resecting it and inserting a mechanical device, which has been done since 1956 by Fernstrom. And there are these rumors, there are many rumors about our former president, John F. Kennedy. One of them is that he was actually the bearer of one of these Swedish ball bearings in his lumbar spine. And from early on, the replacement of discs has created noteworthy and rather vocal responses. So over time, again, developments have really brought further mechanical evolutions down to metal-on-metal bearing devices, which now have again fallen into greater questions. And without reading this busy slide, there is a large number of different replacements, both mechanical, nucleus replacements, and minimally invasive around. So with all these multiple options, where are we? Well, the regulatory perspective is one that basically identifies, are they safe and effective? And from the FDA standpoint, there are very clearly safe and effective devices, ×2, that have been released. And from our own Washington State Health Technologies Assessment Program, which is something we can be really proud of and which is widely looked at and which I hope that all of you will become engaged in as they're branching out in further and further measures, this particular technology was also found to be safe and effective in appropriately select patients. What is the fear? The fear, I think, was that disc replacements would become a tsunami-like just wave crashing in on back care and just basically create extraordinary growth curves such as this here, which would basically swallow our increasingly meager healthcare dollars. So I think that was the third-party payer fear. Well, let's look at the reality. And this is, again, an open online journal, but it has some very noteworthy authors in there, and they actually looked at nationwide inpatient samples. So if you look at where are disc replacements done versus fusions, they're still mainly a metropolitan and half-half private practice and academic kind of a venture. The other thing is how much of a fraction of lumbar surgeries are they done relative to fusions. And if you look at this black line, that a brief blimp up in the 2005 era to about 2.5%, but since then it's ebbed down again. This is again up to 2008. So it's not really had an exponential growth curve. And number three, again, as a portion of lumbar fusions versus lumbar revision fusions versus lumbar arthroplasties are this white little thing at the very bottom. Lumbar revision fusions are actually pretty steady, and primary lumbar fusions have continued a very healthy climb. So again, from a socioeconomic standpoint, they've not become a very major deal. Why not? Well, first of all, the heavy hand of the insurance industry in this country has identified counter to FDA and counter to, for instance, the Washington State HCA-HTA program, that long-term clinical safety and ethics has not been established. And again, the other problem is for us as clinicians, akin to finding Nemo in the Sydney Harbor somewhere. It's really a hard challenge. This is a recurrent theme of just about every single lecture to try to identify the ideal patient. So the great hunt for low back pain is one that really curses our profession to a large degree, and we have had many approaches towards trying to identify it. We've heard great lectures about the oversensitivity of neurodiagnostic tests. And again, we all despise and abhor these kind of scenarios where a patient has just been literally fused from L3 to the pelvis in multiple surgeries without a clear discernible benefit to her well-being. So all of us can really, I think, agree that we should beware of the vomit syndrome. And for those who don't know what that is, right? Everybody know what it is? Victims of medical imaging technology. This is a very big wake-up call. We really need to get together and come together again and find out who we really can help. And the patient selection criteria, I think, are really increasingly clear. Using the same MRI example from the beginning where nobody wanted any treatment, everybody in this room wanted to retire, there are scenarios that we can all identify where the patient may, due to psychosocial circumstances, actually do reasonably well. And conversely, we can all conjure a number of factors that very readily come to our practitioners' minds where the prognosis is probably pretty likely, and you don't have to take big betting odds in Vegas for this, going to be rather negative towards a favorable outcome of any intervention. So the art of patient selection, is it really such an art, or can we actually use relatively simple factors? And again, the list of patients who should not receive lumbar arthroplasty is abundant and is actually quite clear. It's almost a checklist. It's an Atul Gawande type checklist. And we probably need Atul Gawande to come and apply that to spine. And again, the ideal patient for a potential disc replacement surgery is, again, a very clear and very rare kind of a situation. And again, all of us pretty much agree on that. So this new approach in terms of spine care has been reiterated, but putting it together, we have to get better at the phenotyping, and we're getting there. The psychosocial typing, we have the gestalt, the general elements of that, but we're not applying them well enough. And the genotyping, we saw just visionary lectures today by Drs. Kang and by Dr. Kandel, who just really showed us where we can go if we apply our wits better. So the basic questions of an artificial disc are safety and, number two, the outcomes. And that's the basic duality in which we try to see what we're doing. And there are basic 8 concerns about putting a disc replacement in: extrusion, access, neurology, vascular injuries, fracture subsidence, continued pain, stability, and then reactive moments such as heterotopic bone or other reactive soft tissue processes. Mountain of evidence for arthroplasty or fusion in the lower back is actually a very growing and large body of literature, which for the first time really has also brought in numeric fashion a better understanding of what we're actually doing. And again, we're not going to read through all those, but it's a growing mountain of literature. I'm going to give you a synopsis of 3 larger trials. One of them was kind of stopped now, the FlexiCore one, but mainly revolving around the Charité and the ProDisc, and again, mainly 410 patients. And again, these are kind of the summaries. So an ODI difference, the Oswestry Disability Index, of a 15-point or more change in disc replacements was better than in fusions. Was it massively better? No, but it was better. And some were better than others. So in principle, if you put that together, there's about a 3/4 chance to create a 15-point out of a 100 scale improvement of lumbar disc replacement. What about reoperations as an indicator that something did not go well? If you look at that again, in terms of disc replacement versus fusion, again, disc replacements have a lower reoperation rate than fusions in the lumbar spine. You can credibly immediately question the statistic because a lot of the control groups were done front and back, so a way more invasive surgery than the disc replacement. Still, these are the numbers, and I'm reporting them. Overall success, and again, this is using the FDA criteria for success, which is a multi-tiered 8-prong kind of a success checklist. Again, for disc replacements, they did exceed most of the fusion data pretty clearly. It's a little bit closer in terms of the data, but again, this is a composite that we still somewhat struggle with because any single element of the success criteria that is not fulfilled eliminates that particular device. How do patients do in the longer run? Do we have data on that? And yes, this is evolving now, mainly through our colleagues at Texas Back Institute. And this is using the Charité disc versus a fusion model. And again, the concern of the insurance industry is that the longer-term results are not there. Well, in principle, if you look at the green versus the red bars with these 2 devices, they actually compare pretty favorably over time. And again, pain reduction is very similar for both. There might be some differences, but you can really argue whether they're relevant or not. Work status does show statistical differences. And again, particularly in the earlier days, it seems that disc replacement patients can go back to the original job. What about 2-level disc replacements? Well, that's something that is not FDA approved. I want to make that very clear. But again, there, we have, again, on the success side and ODI side, some slight favorings, which are considered statistically relevant by Delamarta et al., and about 237 patients. Again, there are significant statistical concerns, and you can really argue whether the differences of 48 to 68% are meaningful and warrant the cost. But again, they are substantial changes in terms of the pure statistical analysis. Complications, again, that's something I brought up in the beginning. I didn't really answer. The overall true incidence of complications is not known, but it's probably around less than 5% in the select hands of those who have done them in the North American trials. In Europe, the complication rate is really not known, and there have been some troubling reports of significant complication rates, but again, these are usually centers that are known to handle the far more prevalent complications. One of the really big things is, just like artificial hips and knees, will these things wear out? And skeptics like Randy and Alex Vaccaro always say, well, it's just a matter of time until they create foreign body reactions like what we see on this CT scan here. There's no question that in the few retrieval studies that have been published so far, there is indeed some component wear present, but it has not led to known foreign body reactions except for this one well-publicized case I just showed from Australia. But so very early on, this particular cervical disc implant did show some wear and tear in a retrieval specimen. We don't know what that means at this point in time, and we do have to assume that, for instance, metal on metal may create some ion uptake that we don't know of yet. In terms of the Charité, which was a biomechanically very different disc from the others in that it is absolutely unconstrained, the Europeans reported a 10-year follow-up, which 4 out of 5 patients had a good or excellent result using their terms. That's, again, more than 10 years. Again, using a different implant, which had a more restrained mechanism, the ProDisc type device in France, a similar, very, very similar result with 3 out of 4 patients having good results in 10 or more years was reported. One very interesting factor that came out from that same group was that if patients maintained a significant range of motion of more than 5 degrees, patients had a better outcome, and that was in the long run, and they also had a far lower rate of adjacent segment disease. So these mechanical devices, which, as you know, don't have a buffer built into them, actually fared better in the longer run. Which brings me to the next point, and that is motion or motion preservation in a degenerative process actually something good, or can it be something bad, especially if you don't adequately decompress the neural elements around it, and then allowing the connective tissues to rehypertrophy. So this is a very big deal that we don't know of right now, but certainly what that point drives home again, similar to the previous slide on how technical excellence and maintenance of a range of motion of over 5 degrees may indeed affect results. Technical attention to detail may be far greater a challenge than anything else in terms of the actual surgery. And certainly the reactive hypertrophy, such as seen in this lumbar spine, may be a rate-limiting step. And again, has to preempt it probably by really doing a far greater decompression than we usually would do for a fusion. How long do we need to follow up until we convince the insurance carriers that these are safe and effective procedures in the longer run? Well, nobody knows. The Swedish Spine Registry is not there, but the famous Swedish Hip and Knee Registry has accumulated data for a long time. And again, for them, the 10-year point was really the main mark of a change. And again, by 10 years, 10% of implants would fail. So this is something that we can use as a benchmark for our own statistical purposes. And we're getting close. In this country, about 3 years away from having 10-year data for lumbar discs. So the disc arthroplasty summary in mechanical devices can be identified as the results are not inferior to fusions. They may have some trends towards improvements, but we don't know how long they'll last, and again, if they'll fail at 10 years. Contrast that with the one big factor, and that's again the best data that we have so far, and that is adjacent segment pathology in the lumbar spine following fusions, which does seem to have a clear time component. And again, right now, the data in the lumbar spine at least seems to favor disc replacements over fusions. So the summary of results identifies that it seems to be safe in a controlled environment, and this brings us back to the age-old argument of efficacy versus effectiveness in a large, unregulated environment. The results are largely similar to fusions. There may be some favorable results in terms of recovery time being shortened. Patient satisfaction seems to be clearly higher in patients who expect a disc replacement over a fusion. Adjacent segment disease, I put a big question mark on that. Reoperation rate seems to be favorable, and cost may indeed be lower for disc replacements. This is, again, an opportunity for all those who like to philosophize about glass half full versus glass half empty. Again, the results are relatively close towards fusion, and again, where you place your favoritism may be a matter of preference both from the patient side as well as of the surgeon's side. Why all these questions then? Again, remember, one thing about disc replacement that is even more accentuated than in fusions is the fact that we need to be absolutely perfect in terms of where we put these implants and how we select these patients. And this raises the very controversial issue of who should actually do these disc implants. Should it be just a couple of people who literally have done thousands of these? How many stars do we really need in North America? Well, maybe not that many. NAS estimated that probably really good candidates for disc replacements, at least in the lumbar spine in the US, may not be more than about 200 to 2,000 a year. Quite clearly, these mechanical discs that I've just shown are a far cry away from our human discs, which, as you've seen today, and I think it's a repetitive theme also, are just a really miraculous entity. And we don't have a good biomechanical, crude substitute for those at this point in time. Another final concluding thought is, and that's the final concluding thought, lumbar arthroplasty is clearly, as has been shown, not a cure for back pain, but it may be a reasonable alternative to fusion in very specific indications with great attention to technical detail and perhaps a dedicated service line. With that, I thank you.
I will finish up this session by a quick review of the some other in the motion sparing the approaches. Dr. Kandel and Dr. Kang talked about the biological approaches, so I'm going to just focus on the mechanical approaches. This is my disclosure, and the lumbar fusion has been the standard of the care for the stabilization of the spine. Arthrodesis has the related mobilities, including the osteoarthrosis and then adjacent segment degeneration. The adjacent segment degeneration incidence is reported like based on the radiographic findings about 5 to 100%, depends where you look at. And also those required surgeries about 16.5 at 5 years and up to the 36 at the 10 years. And the pathology of the adjacent segment degeneration, including the degenerative disc changes, the facet arthroplasty, and the stenosis, and the diseases. The goal of the motion sparing surgery is that number one is to maintain and restore the controlled motion at the treated segment, and also to reduce the risk of the accelerated degeneration at the adjacent levels. Which is a major concern with the fusion. These two goals are the motion sparing surgery. If you cannot achieve these two goals, then the motion sparing is no good. Now, the options besides the artificial disc that Dr. Chapman talked about includes the nucleus replacement, and then the interspinous process spacers, and also the pedicle-based systems. These two the devices is mainly restrict some certain types of the motion and alter the load transfer through a functional spinal unit. Let's first look at this the nucleus replacement. Now, as we know, the surgical entry into the disc space often results in a gradual loss of the disc space height. The removal of the entire nucleus pulsus will change the biomechanics of the remain disc, and then partial removal of the nucleus pulsus can result in an inability of the disc to resist the compressive loads, and also leads to the accelerated degeneration of the annulus and the facets joint. There's a clinical investigation by using the hydrogel, which there's 3 forms. One is the in situ curable polymer, which is injected as a liquid into a balloon, or it just directly injected into the disc space, and then it's cured into form a kind of gel-like structure. And also there's a preformed polymers which is inserted directly into the disc space, and also there's a combination of the both. Now, this prosthetic disc nucleus, which has been tried clinically, they tried at 10 patients, at least with a 2 years follow-up with the Prolo and the oswestry scores, which showed the excellent results in the 8 patients. And radiographically, they can restore the disc height and the normal motion. However, there's 3 patients had the device migrated, but only 1 required surgery. And also this, the prosthetic disc nucleus has also tried through a transpsoas approach, which is just like exactly like the X-leaf approach, and they can put in 1 this prosthetic disc nucleus, and also they can put in the 2, and then they also close the annulus to ensure that the placement of this the device. The clinical study, they tried it in 8 patients with 1 year follow-up, the oswestry and then Prolo scores has been followed, and then 1 patient had endplate subsidence and also had the reduced disc height, and 3 patients had the anterior migration of this device. Now, there's some other investigational devices. One is this Aquarel, which is like they inserted in as a dehydrated form, and then over the time it absorbs the waters in the disc space, can swallow so that it can increase the disc space. And also this nucleus one, which is a kind of have a memory coiling property that you can insert it through a small opening on the annulus, and then it can coil up, and then to become functional. And also this new disc, which is inserted into with a dehydrated form by using the minimum invasive technique, and also after absorbing the water, it can expand it like vertically, so that it increases the disc height. Now, the concept of this, the nucleus pulsus replacement, is that the implantation of this device requires the far less surgical exposure than those for the disc replacement. And then the nucleus pulsus replacement is better resembles the native disc and allows for the vertebral translation and axial loading. And the promising early results has been shown in the very small numbers. However, currently all the nucleus pulsus implants are still considered as experimental, and so far there's no data with the prospective randomized trial to determine the efficacy and also even the indications. The second one is the interspinous process spacers. This interspinous process spacers develop as a bumper, which can cause the facet distraction, can decrease the intradiscal pressure, and also reduce abnormal segmental motions. Essentially, this one is designed to dampen the existing painful motion of the treated segments. Everybody knows there's the X-stop, which is the most popular one, and then there's a DM from the Medtronic, there's the Wallace system from the Austin, Texas, and also there's a Coreflex from the Germany. The most studied one is this X-stop. Initially, the Zuckerman published this data, treated 100 patients with a neurogenic claudication with a 2 years follow-up with the Zurich claudication questionnaire. 73% of the patients was found that satisfied with their treatment. And also, Kuchita had published this data with 175 patients at 4 years follow-up with the VAS score and the oswestry and even the functional MRI with the flexion and the extension, the picture, which shows both VAS and the oswestry has the significant improvement after the placement of the X-stop. However, later, as time passed, there's a multiple results which shows that it's not so promising. And the Tertial published this data shows in the 46 patients with the 40 months follow-up, the pain level and the SF36 and oswestry has been followed. The revision rate in this patient was found to be 30% due to the lack of the improvement of the 6 weeks follow-up. Therefore, they concluded that the clinical outcome might be considerably less favorable compared with the previously being published. And also, Daly published this data with the 13 patients with the 4 years follow-up. The pain level, SF36 and oswestry has been followed. Initial pain improvement, although it reached 72%, but later on, the recurrence of the pain reached 77%, and overall, the complication rate was 38%. More importantly, there's 85% of these patients required additional surgery due to the failure of this device. Now, there's many similar devices around the world, outside the United States, but the complications of this device has been well published, including the dislocation of this device, malpositioning during the surgery, and also the spinal process fracture, erosion of the spinal process. Now, the X-stop, whether this can prevent the adjacent segment disease. Now, there's no really published data in the clinical trial to show whether this can reduce adjacent segment disease. However, as we know that this device can reduce the flexion and extension range of the motion at the treated level. And also, there's a biomechanical study shows that in the cadaver, there's a significant increase in the range of the motion at the adjacent levels during the lateral bending and the rotation. Therefore, it's speculated that it will increase the risk of adjacent segment degeneration. Next will be the pedicle-based system. In the United States, there's only 2 systems has been the results of the significant clinical trial published. Number one is this graft ligamentoplasty system. First, it was introduced by Graf in the 1992. And then the pedicle screws was inserted just like the fusion procedure, and also they are longitudinal, connected with the braided polyester bands. This band has been tensioned so that it limited excessive flexion, but does not limit any extension motion. It can offload the stress on the anterior annulus. However, it increases the pressure on the posterior annulus, as you can imagine. The early clinical trials, Graf initially reported that the patient has 80% of the patient population has satisfaction at the 6 and the 24 months, but this was criticized that all these results are not quantified it, and they were just purely descriptive findings. And Kanayama published the data of the 5 years follow-up with 64 patients with degenerative spondylolisthesis, and the VAS and the sciatica pain score has been followed, which showed the significant improvement, but the lordosis and the segmental motion was maintained in 80% of the patient. And the Gardner, at the 7 years follow-up with the 50 patients, shows that 61% rated their outcome as good and excellent. And the Maiden published this data compared with the graph with the ALIF procedure. At the 2 years follow-up, the ligamentoplasty with the graph technique results the statistically superior clinical improvement. Now, there's some not so promising results afterwards. The Gravit published this data shows that 24%, the rate of occurrence of the postoperative radiculopathy is secondary to the iatrogenic foraminal stenosis, secondary to the tension that they put on the posterior the area. Kanayama, the same group that published the previous data in the 5 years, and then at the 10 years follow-up with the 56 patients, shows that there's 32% of the patients experienced the spontaneous facet fusion, and adjacent level disc disease that required surgeries reached like 7%. Now, the long-term results from the graph ligamentoplasty was not as encouraging as the early results has been. And there's some lots of more unfavorable reports. Rigby published this data shows that the 11 patients had the reoperation rate, which 7 of them needed eventually the fusion. And then the pre and the postoperative back pain score has no significant difference. 41% of the patients choose not to have this procedure done again, when they ask this question. And Hardelow published this data compared with the graft procedure with the PLEAF. At a 1 year follow-up, the clinical score was actually statistically superior in the fusion group. At 2 years follow-up, the revision rate for the ligamentoplasty was significantly higher and associated with the poor outcomes. Bottom line is the graft ligamentoplasty has not been FDA approved to be used in the United States. Now, the second system which has the significant clinical trial is the DISEASE, the dynamic stabilization system, which was introduced in France in the 1994, and then it is similar to the graph, the system, but there's a polyester in the cord to resist excessive tension. Around this cord, there's the polycarbonate, the urethane spacers to resist the excessive compression forces on the back. And then the biomechanical study shows that in the cadaver, it restores the extension range of motion to the degrees comparable to the normal subjects, and also it significantly decreased the flexion and the lateral bending range of motion, which is similar to the fusion. Therefore, they concluded that the DISEASE instrumentation was more capable of providing the stability and the motion. However, keep in mind the motion that is retained with the DISEASE system differs substantially from the native motion that the human spine is supposed to have. And then the pressure loading in the pattern has been studied as well. In the disc space, it only can decrease the load across the disc during the extension and the lateral bending motion. But on the facet, actually, it has increased the loading in the flexion and the lateral bending. Now, clinical trials, there's several papers published there. Some of them suggest that the decompression with the concurrent DISEASE stabilization has the same results comparable to the decompression with the rigid fixation, and some others suggest that you may have more favorable clinical outcomes with the DISEASE instrumentation. However, the GROB published the data with 50 patients compared with the fusion at the 2 years follow-up. The patient-oriented the outcomes were not better, and the reoperation rate reached the 19%. Now, whether this DISEASE system can prevent the adjacent segment disease. Initially, this report shows that it may have shown some promising results that can prevent the progression of the segmental degeneration. However, the Sinai the later published data and also the Kumar's data shows that adjacent level, the disc disease happened in about like 20 to 30% at the 10 years follow-up. Therefore, it's no better than the fusion rate that we showed that initially. In United States, the FDA approved the DISEASE system for the use only as an adjunct to the fusion. The use of the DISEASE implant without fusion is currently considered as an off-label use. The reason they approved this for the fusion with the fusion is that to stabilize the segments above or where the fusion is, so that try to prevent the adjacent level disc disease. That's the original purpose. Now the concept first is this a total posterior arthroplasty system, which is short for the TOPS, and this one is essentially a artificial joints designed for the posterior like facets, and then the biomechanically can restore the lateral bending and axial rotation. McGaffey groups tried this in the 29th patient, and at the 1 year follow-up, it shows that it's be safe and comparable. It can be a comparable alternative to the fusion. The unfixed two system, which is they use semi-rigid rods that can are composed of the polymer sleeve around the titanium cores, and so far this one has FDA approved this one use as adjunct to the fusion, but there's no published results yet. The last one is this Max NZ system. This one has the dual concentric springs and with the ball and the socket joints. However, there's very limited data and currently is still under the IDE trial. Now, in conclusion, the NUCLEUS pulses implants is still experimental, and then the interspinous process spacers has a poor long-term outcome, and the pedicle screw-based dynamic system so far shows no better than a fusion and does not prevent the adjacent segment disease. Now, the few soft stabilization systems that have had the clinical applications so far produce a clinical outcome just barely comparable to that of the fusion, and there's no prospective randomized control trial yet to show that is better and even show the indication, which is the essential needs for the practice of the evidence-based medicine. So my final conclusion of this is that nothing else works so far besides what we do normally. Thank you.